I'm going to talk about the visual rehabilitation in keratoconus by various contact lenses. It's not moving forward. Okay.
Click or center, sir.
Yeah. As we know from the global consensus on keratoconus and arthritis diseases paper, the management of algorithm. So whatever procedure you do, whether it's a CXL or you do a some sort of what we call in segments or anything for visual rehabilitation, we have to prescribe some sort of spectacles or contact lenses, and depending upon the degree of keratoconus or the K reading, different contact lenses are indicated. Once the K readings are 45 or flatter than 7, you may go on with the simpler type of contact lenses. If the K reading is little on the curvature is more, then maybe rose K2 is indicated. Once the K reading is between 6 to 7 millimeter, the ordinary lenses doesn't work so well, and we have to use specialty lenses like rose K2 or hybrid lenses. And once the keratoconus advances much more, like 5 to 6 base curve or the K reading, you have to resort to advanced rose K2 or clear lenses. And what about, we have talked so much about the corneal collagen cross-linking. So what about fitting contact lenses after a cross-linking procedure? As we all know, there are no clear-cut recommendation regarding whether when it is safe to resume contact lens wear after corneal cross-linking, but it is usually done 6 months post C3R. But if we have done a epi on C3R, we can resort to use of contact lenses maybe at 3 months time, because as we all know, the K reading as well as corneal thickness keeps on changing approximately till 6 to 9 months after the C3R. So I will be emphasizing basically on rose K and scleral lenses, because the shortage of time, it is difficult to cover all the types of lenses. Way back 15 years ago, we published this rose K contact lens paper in IGO. And as we all know, the standard lenses designed with fixed optical zone diameter don't fit to the cone shape of the keratoconus. And the standard lens, in that we have an unwanted pooling uh, and a peripheral bearing seal off, which cause a lot of problem. Rose K have a smaller optical zone, and it fit to the cone contour, and there is no pooling, and even distribution of tears are there. So I won't go into the fitting philosophy that you all know. Depending upon the K rating, we start with the trial lens, which is either 0.2 millimeter steeper or same K, or 0.4 millimeter flatter, and size is determined depending upon the horizontal visible iris diameter as well as the palpebral aperture. And the fit is most important, because that is what makes the patient comfortable. Otherwise, the discomfort is there. First, we have to see that the central, there should be gentle apical central touch, and then there is will be should be a mid peripheral bearing of the rose scale lens. And most important is the peripheral edge lift, which should be around 0.75 to 1 millimeter. And as you can see in this case, this is a very flat fit with the central bearing, and this is too steep a fit with the mainly peripheral, mid peripheral bearing and very minimal edge lift. And you should have a dynamic assessment of fit. Patient should be blinking. As you can see, immediately after blinking, you can see a little bit of central bearing when there is a pulling away. So you let the lens settle down and then do it. So, so this is a okay fit in this case, and the edge should lift is very important, because if it is less, then there is a lesser exchange of tear, which hampers the corneal health. And then you finalize the total diameter and do over reflection and add on to the basic lens power, and that's how you prescribe these lenses. And this is a representative case with grade 3 to 4 keratoconus on both sides, and this we have fitted. There is a central scarring in this case, but these lenses, as you can see, they are flat in both the eyes, and by doing a more trial of the lenses, you can have a central bearing with the mid-peripheral bearing, and because these are toric fit, so you can see a dumbbell-shaped pooling of the dye. So coming to scleral contact lenses, we have experience with this Valley Contact custom stable scleral contact lenses, and this is the lens anatomy. This has a central clearance zone, which should be 150 to 250 micron clearance from the cornea. Then we have a mid-peripheral limbal independent transfer zone, and this offers an independent customization of the limbal clearance, and it should be around 50 to 100 micron clear of the cornea. And then we have a scleral landing zone, an angle that aligns on the sclera and bearing sector of the lens. If on this scleral bearing landing zone, the lens rests on the sclera, and we have two types, oblate and prolate type. Prolate are ideal for ectatic cornea and all forms of keratoconus. And this is how you go about changing the lensing depending upon whether the clearance is less or more. You can move in 100 micron steps so to have a optimal central clearance, and to have a the limbal independent transfer zone adjustment. These are available in 15 micron steps, and then the scleral landing zone. It is again available in 13 micrometer steps. So you should have an optimal scleral landing zone adjustment so that there is no impingement or excessive elevation. So I won't bother you with the fitting philosophy of the lens. You should have a clearance of around 200 microns. Wait for the lens to settle, and then assess that whether there is a good clearance between 200 to 300 microns. And the limbal clearance should also be evaluated and tuned so that you have a 50 to 100 micron of post settling, which is ideal. And this is a landing zone evaluation after a settling of the lens. And 0, this marks indicates the flat meridian of the lens. And this is a little tilted around 20% degree right rotation. So once all the parameters are settled and you are satisfied, we over refract and then prescribe the lens. This is just to show on OCT that this is the 50-50 rule. There is half of the edge lens is impinging on the sclera and half of it is above it. And this is too much of edge lift in the middle, and the last one is digging in. This should not be done. And the first one is the very good alignment. Second one is the edge lift or flare, what we call, and third one on the lower side show there is an impingement on the sclera. And this is a representative case with the grade 2 keratoconus on the right side and grade 4 on the left side. And we can assess the fitting on the Garcia OCT. Also, you can see there is a clearance of around 235, and this is another case showing this thing of clearance of 300 micron. And this is the bilateral both eye fitting with the this scleral contact lens. Patient gained almost 6.669 vision in both the eyes. And this is another case. Here you see zone clearance zone is around 180 micron, and this is post keratoplasty eye. And you can adjust just this is the last line. So the clearance zone you can adjust depending upon the fitting philosophy. So to conclude, whatever stage of keratoconus you have, various modalities of treatment we have already discussed in the course of instruction course. Next, Dr. Ketyal will be talking about the choice of keratoplasty. But whatever procedure you need to optically revalidate these patients with either spectacles or contact lenses. Thank you so much for the patient hearing.